kidding. Okay, we're live.
Hi everybody, I'm Dr. Sears with Living Hope Eating Disorder Treatment Center. We're based out of Norman, Oklahoma, and we're going to do just a short question and answer session for NEDA week. So I'm Dr. Sears.
I'm Lindsay Poe, I'm a therapist.
And I'm Kara, I'm a dietitian.
So we're just going to kind of get started with some of the questions that you guys have submitted to us. They're all great questions and we really appreciate all the feedback that we've received.
Okay, so the first question we got is, do you believe in or use EBT, which is emotional brain training, as an effective co-therapy? And actually, I use emotional brain training, EBT, in the majority of my groups. Emotional brain training is almost like the rewiring of your brain. So if you tentatively lean towards more negative thinking, EBT focuses on positivity and creating new neural pathways in your brain so that you lean more towards positivity and you get out of that negative mindset. And you do that by just repetition and using positivity in almost every aspect of your life, and just reframing and using those things so that you lean more towards positivity, not only in eating disorders, but in everyday life and every aspect that comes up. The second question was, what are your thoughts on FBT? Which FBT is family-based therapy. It is actually used very successfully in treating adolescent eating disorders. So family-based therapy is not the same as family therapy, which is what you would typically think about. It is actually the very first step is to get the family involved in treating the adolescent eating disorder. So the first step is to get that child nourished, and you do so by giving complete control of the child's meal plan and their decision making back to the parents. So once that kiddo is nourished, then the second step is to reintegrate age-appropriate decision makings for that child. And then the final step is where they completely gain their independence back and are able to deal with their meal plan and eat effectively and appropriately once again.
So the next set of questions that we got is, why is the standard of care so different from state to state? For example, why do you think a child in the hospital for anorexia in Oklahoma is treated with different therapies than someone hospitalized in California? And insurance companies and others demand similar evidence-based treatment for things like pneumonia and sepsis, but eating disorders seem to be a gray area. So the first thing that I would say is that we do have standards of care for eating disorder treatment, and the gold standard of care for eating disorder treatment is based upon the APA criteria for levels of care guidelines for eating disorders, and those are very clear in what is supposed to dictate treatment for inpatient levels of care, residential level of care, partial hospitalization care, intensive outpatient level of care, and outpatient level of care. And so at Living Hope, that's what we follow to determine whether or not a patient needs a certain level of care. So basically, whenever we're evaluating the patient, we're seeing what's going on with them and where they fall based on APA criteria. And then based upon that, I make my recommendation on where I think the patient should go and which level of care they should go to. And so as far as whether or not every place does that, like, I can't really speak to that. I know that's what we do here. I know that there are some differences in the way that people do approach treatment. I think in general, CBT is a very evidence-based mode of treatment for therapy for eating disorders, and so we use a lot of CBT here, although we do also do some other co-occurring co-types of therapy for different things going on with the eating disorder patient, and we do individualize the treatment. And I think the thing is that one thing that's a very different situation for eating disorders versus say pneumonia or versus sepsis is that the underlying things that are causing those things are very specific. So it might be hypovolemia, and so they're hypovolemic shock or whatever. So you go through these algorithms in your head about what is the cause of this thing for the patient, and then you treat it with X, Y, and Z, and that works all of the time, or that has the best chance of success. But these patients are individuals, and they have very different histories, and so they may have had a serious trauma of some kind that is very different from someone else's trauma, and they may have depression, or they may not have depression. They may have anxiety, or they may not have anxiety. They may have OCD, they may not have OCD. And so the patients that we're treating have a lot of comorbidities that are going to be different for each patient. And so we're not really doing a good job for the patient if we're not addressing those individually. And so that's, I think, where you're gonna get some of the differences in the approach that may happen because the patients are individuals and the underlying reasons for why they develop the eating disorder can be quite different. But as far as like what level of care the patient requires per the criteria, that is APA all of the time. Now, unfortunately, insurance companies do not always follow the gold standard of care and have actually been successfully sued multiple times by patients for that reason. There are other criteria out there that are not peer reviewed or actually shown to be effective in any way, but some insurance companies still choose to use those along with APA or in place of APA. One thing with the healthcare law that the ACA that passed is that there's something called mental health parity law, and per that law, people are supposed to be treated when they have mental health issues per medical criteria. So if they have medical criteria for needing a treatment, then that is supposed to be covered per federal law. And so those are the arguments that we often will make with insurance companies if they're trying to deny a patient a level of care that they need per medical criteria, and that's something that can be argued, usually successfully. But that can become difficult sometimes. But certainly we always go ourselves by APA because that's the gold standard level of care. And should anything go to a court, that would be the standard of care that would be brought up to see if what the patient had warranted the treatment that was being given.
Well, the next question we received was, how do you best approach the topic or concern with someone that you think might need some treatment for an eating disorder? My personal philosophy is always honesty is the best policy. When you are concerned with someone, when you're worried that they might be struggling with some sort of eating disorder, it is my suggestion that you take the list of your concerns or your reasons and you sit down with that person and you not only go over them, but you ask them where they're struggling. If your feelings about that person are valid, and then not only have that discussion with them, and I know it's a very hard discussion to have, but then also have a list of resources so that if that person is in agreement that they need help, that they need some sort of help with their eating, that you have a list of therapists or treatment centers that they might be able to investigate and how you get a hold of them. That would be my suggestion. Also include as much family as you can to approach them. I know it's a very delicate subject, but I would highly suggest sitting down, having a frank and open discussion with them. That would be my advice to you.
Okay, next question we had was, why are eating disorders so terribly hard to overcome? And I think that this is a really big question that encompasses a lot of why people develop eating disorders in the first place. And kind of like Dr. Seuss was saying, there are so many different reasons why. Everybody has different backgrounds. People develop eating disorders for different reasons, for different coping mechanisms. So it's all on an individual basis. And I think from a dietitian's perspective, it takes time to work with someone and re-nourish them when they're really sick, get them back to a baseline so that we can start working through and talking about the food issues that they have and reintroducing foods that they're fearful of and talking about this. And it can be a really long process, and that's hard for people to stick with it and be consistent and keep coming back and talking to the dietitian, talking to the therapist about their struggles. So I think that's a big reason why it's so difficult, is because it does take a lot of time to work through a lot of the things that people are going to go through.
Yeah, and I also think, so there's a lot of parallel discussion a lot of times between patients with eating disorders and patients with addiction, but there's some pretty significant differences between these two groups. So with addiction, you're dependent upon a substance of some kind, whether that be alcohol or some kind of a drug, but you can go through a detox period and then live the rest of your life sober, and you are not required to consume in those substances in any kind of a certain exact percentage and still be okay. With eating disorders, we're dealing with patients that are struggling a lot with eating appropriately. They are either struggling with eating enough food or a good variety of foods, or they're struggling with eating too much food in a setting and then engaging in compensatory mechanisms for those things. And so what we're doing is we're actually having the patient engage with food in a normal way for maybe the first time in a very long time. So they have to learn how to eat just enough not too much, not too little, but exactly what their body needs. And that can be very difficult because they're not able to just abstain from the food the way that you can abstain from a substance. So I think that that's a lot more tricky in some ways than substance abuse. And another thing I think that's a little bit different about these patients is that they are so malnourished, and that affects their entire body and the way that their brain is able to think. We know that like brain mass loss occurs at the height of anorexia, and so we're having to restore the body, we're having to weight restore the body, and then allow time for them to heal, which takes time. And so they can remain sick for quite some time. Even after weight restored, it can take some time for things like vital signs and things like that to improve. And for the weight restoration and things like that have occurred to kind of shift back into the organs and heal those organs so that then they're able to have appropriate insight. So all of that just takes time. And so it seems to be a bit of a longer process sometimes than some of the other things that are treated. Okay, so the next question is, what is ARFID and why isn't it being properly diagnosed and why isn't it known? So ARFID stands for Avoidant Restrictive Food Intake Disorder. It is a relatively newly named disorder. So it got a name for the first time in 2013 in the DSM-5. So that's not that many years ago. Prior to that, I think it was sometimes recognized as a disorder, but it would have been under the other specified feeding and eating disorder category and did not have specific criteria. So I think anytime there's like a new diagnosis, it takes time for it to become well known. It takes time for there to be research on that disorder because until you have a name for a disorder, you don't really get funds from grants and things like that to do research into a disorder. So I think it will just take time for the disorder to become more well known. I do think that I'm seeing more patients with ARFID than I have in the past, and I think that the patients with ARFID that get treatment do very well, just like with other eating disorders. So that's, I think, that question. And then the last question that we got was, what are your personal goals for 2020? So I think for Living Hope, what I would really like to see is just for us to kind of continue to be able to grow, to be able to continue to provide really excellent service to the patients that we see, be able to help people get better and get their lives back, and just be able to continue to provide education and awareness to the society at large here in Oklahoma, and just to take care of people and keep saving people's lives, which is what we love to do.
Yeah.
So I think that's it for now. So we really appreciate you guys joining us today, and we hope you learned something. If you guys have other questions that you'd like us to answer for you, you can send them to us, and we can try to get back with you with some answers at another time. Have a good day.